All right, good afternoon. Everybody's sitting in the back. Did nobody used to sit in the front in med school? Is that all? It's all of y'all are just like in the rear. So it's a GI day in the rear. Okay. All right. So this is going to be some high yield points on the polypoid syndromes and some real basic pathophysiology. And I want to hit on the colorectal cancer hereditary syndromes, and then I want you all to be experts in the difference between screening and surveillance when you're done. And for those of you who like zone out in the middle or go to sleep or something, this is what I want you to remember, okay? When to start screening, what age, and then I want you to remember that there's a large armamentarium of different options for how we can screen and do surveillance. Colonoscopy is not the only answer. And so there's two different arms. There's a diagnostic arm and a preventative arm. I want you all to know about that. And then I want you to know what exactly it means to have a positive family history. And I also want you all to know the difference between an advanced adenoma and a simple adenoma. And so let's get going. Everybody knows that colorectal cancer is very, very common. It's like the second or third most common malignancy. And I guess there's maybe, 80 people in here or so? 100? I'm not sure. Anyway, I mean, 5 out of 100 or 6%, I'm sorry, are going to have colon cancer in their lifetime. So, look around and you'll figure out that some of us are going to get it. All right? So that means everybody's going to get screens. This should be a preventable illness. This should be preventable. Most everybody who gets colon cancer is going to be sporadic. Almost everybody. There's going to be a group of people, about 20%, who have a positive family history, but they don't have any known genetic defects, known genetic syndromes. And then there's going to be about 5% that are going to have one of the two that we know about, which is Lynch or FAP. Lynch is more common. There's also some risk factors. These don't really affect or change the way that we practice medicine right now, but they may, and so I just wanted you to be aware of them. The risk of obesity in some of the more recent studies is somewhat equivalent to the risk of having one family history, one family member, one first-degree family member with colon cancer. So obesity seems to be increase your risk by 1 to 1.5. And as you know, the inflammatory bowel disease, the chronic inflammatory changes inside the intestine like IBD and Crohn's can increase the risk for cancer. There seems to be a higher prevalence in the African American population, and their mortality is worse. And that might have something to do with being screened less readily. And it's more in men than in women. Also, there's some diseases like acromegaly and cholecystectomy. All these have been associated with increased risk of colon cancer. So just keep that in mind. But like I said, it doesn't really change what we do right now. The older you get, the more likely you're going to have an adenoma. And as up at 70 years old, about half the population will have an adenoma. What percent of adenomas turn into cancers? Is it a lot or little? It's a little. So only about 5% of adenomas really ever mature into a colon cancer. But a percentage of adenomas is an important factor. As physicians, all of us are entering into this new phase of being graded and judged on, put on the internet, and all of our stats are everywhere. One of the things to keep up with in terms of endoscopists is the adenoma detection rate. That's probably the most important in regards to quality colonoscopy. And you guys are going to be sending people to get endoscopies, and you're going to be picking people to do your endoscopy. It's a long time for most of you, but remember, what you want is a good quality endoscopy. And adenoma detection rate is one of the most important indicators. And then withdrawal time is another. And so as these parameters become more and more common in our practice, look for those kind of things in regards to who you pick to serve your patients. And then you might see it on your boards, the strep bovis or the C. septicum. if you see that on one of your questions and that's in their blood, then think about colon cancer. Now, I put this up to remind you of how long it takes. It's a long process from the normal mucosa to a adenoma to a carcinoma. Up there, it has you can see here that it's like from the beginning to the end, it's about 15 years. That has implications in terms of how often someone gets a surveillance, how often they should have repeat colonoscopies. The second important thing about this slide is this is the mucosa, and then this is the muscularis mucosa. And above the muscularis mucosa, there's no lymphatics. In the submucosa is the lymphatics, and then of course further out into the wall of the colon. But the point that I want to make is that lesions that are in the mucosa that are above the muscularis, those are treated completely with endoscopically. So if you see a question about a tumor that's intramucosal, or sometimes it's called carcinoma in situ or high-grade dysplasia, what that means is that they're all above the muscularis, and if you've cut them out, then you have cured. That's a cure. So keep that in mind. It's a very complicated genetic process to go from normal mucosa to a carcinoma. There's a number of tumors, oncogenes and tumor suppressor genes and mismatch repair genes that have been identified, and this combination of genetic alterations leads to cancer. And in terms of solid organ tumors, this is maybe one of the better worked out in regards to the different genetic defects. I'm going to talk about the microsatellite and Lynch syndrome in a little bit. One thing to keep in mind, and that's what this is referring to, is that except in specific instances, such as an inherited disorder or inflammatory bowel disease, the process takes a long time. Those examples are accelerated. They accelerate the progression from a normal mucosa to adenoma to carcinoma. Colon cancer is eminently survivable. It's about a third of the people who get colon cancer die from it, but the earlier you catch it, the better. And a differentiating point is whether or not there's any nodes. So the earlier surveillance, earlier screening in regards to preventative is better. And so this is what we don't want. We don't want to find a multilobulated erythematous friable lesion, which is right here in the cecum. This is all normal mucosa. See, it's nice and smooth up here. These are the normal valves. But that's what we don't want to find. We don't want to find somebody who already has a well-differentiated mass. Adenomas are glandular growths. An adenoma in the intestinal tract is by definition neoplastic, which means it has malignant potential. The neoplastic tissue can have a low-grade dysplasia, high-grade dysplasia, or become carcinomatous. So if you see on the path report that it says adenoma, then you know that that's a neoplastic process. This is what we do want to see. We want to see a nice, well-differentiated polypoid area here. This is the snare, but you can see this is nice and well demarcated. If I'm going to find a polyp, I'd like to see something like that I can resect and then follow up the patient down the line to make sure it doesn't return. Now, this is to remind me to tell you to get familiar with the path reports. I think that's one very important aspect of medicine, internal medicine, that we can all do together, is know what's on the path report for the patient after the patient's had a colonoscopy. I have plenty of people who refer to me that say a history of a polyp. But if you're going to refer them because they have a history of polyp, know what kind of polyp it was, because it makes a big difference. The neoplastic polyps, which I've told you about, or which have malignant potential, they're almost always it's going to be an adenoma in the colonic mucosa. Most of the adenomas are tubular, which are usually low grade in terms of their dysplastic potential. More advanced adenomas have a villous component, or they're completely villous. As you can see, those are less frequent. If you see on the path report that it talks about a serrated polyp, those have malignant potential. So these are really good reasons to send somebody to have repeat colonoscopies. There's individuals that have non-neoplastic polyps. There's no malignant potential. So when you read the path report and if it says hyperplastic or inflammatory or a hamartomatous type polyp, then those individuals typically do not need further evaluation because their polyps were not precancerous. Okay, now let's do some terminology and some guidelines in regards to when people should have endoscopy and when we should start, when we should stop, and how often we should do it. First of all, know that there are a number of different guidelines. Why do you think that there are multiple guidelines? These are just 3. Why do you think there's a whole bunch of them? Because there's not good consensus. Because there's lots of opinions. And so that's good news. It means y'all can have an opinion about what you think is appropriate for your patient. You can individualize your decision, and you can choose the modality that you think is more appropriate. The ACG, the way that they've designed their guidelines are based on what they think is the one single best test to perform. And guess what that is? Colonoscopy, right, of course. The joint guidelines from the Cancer Society and the Colorectal Society and the College of Radiology, their guidelines are based more around a focus on what would be the best thing for the patient. What would the patient pick? What would the patient do? We would like to engage more people in this process. Right now, in the U.S., it's relatively flat in terms of the percentage of patients that are actually getting screened. And so I think that's one of the emphases that they are making is maybe if we broaden our scope, if you can invite patients other than having to have a colonoscopy, we can have more people screened. So you'll see in their guidelines that they ask people to consider more strongly than the ACG does for virtual colonoscopies and for stool guaiacs and so forth. This group, their focus is on what do we have that shows the absolute best data. And so their guidelines are different than the other two. So let's talk about terminology. What's the difference in prevention and detection? And when would you pick one and when would you pick the other? Prevention, a prevention strategy, or the prevention arm, is looking for things before they get started, which would be looking for adenomas, looking for mucosal aberrancies before they become a malignancy, before they start giving you symptoms. The detection pathway means that there's enough aberrancy in the colon to create symptoms, or signs, enough aberrancy to create signs, which would mean bleeding. So they would have stool, the DNA in the stool would be aberrant, or perhaps based on the FIT test and the stool guaiac cards, you'd find blood in the stool. If it's okay to pick either one. It's okay to pick either of these pathways. But once you pick a pathway, then it's okay to stay on that pathway. If, for example, you choose a prevention pathway and a patient has a colonoscopy and they come to your office 3 years later, do they need a stool guaiac card? They do not, okay? And if they're getting yearly stool guaiac cards and one time, and then the stool card turns positive and they agree to have their colonoscopy done, then when they come back to you the next year, do they need you to continue doing stool cards? No. So pick a pathway, but you don't have to do both of the pathways. Notice like the multi-task force recommendation here is to ask you to think about using a barium minima in your armamentarium. It's hardly ever, we just don't have the experts anymore almost to get that done. So I would suggest the virtual colonoscopy, which is almost identical. The task force and the ACG recommend that you use the immunochemistry test for the stool cards as your detection pathway, and not the sensitive guaiac cards. So it's something for you to consider. Talk to the patient, engage them in the process. There's a number of patients who no matter what their age, they think if it's not broke, I don't want to try and fix it. So they won't come for their colonoscopy. But you can talk to them and say, well, let's do some detections and see if we can find something that's broken, and then perhaps then they will engage in the process of preventative medicine. So that's prevention and detection. Prevention versus detection pathways, which the guidelines give you clear direction. Screening versus surveillance. What's the difference in screening versus surveillance? Screening is when a patient without any other known condition is presented looking for a diagnosis or a condition. Surveillance means you already know that they have that propensity or they have that disease, and then we were going to be following them. So if somebody has had a polyp and it was in a tubulovillous adenoma, one of the things that tends to happen is patients are referred for their screening colonoscopy. Well, they've already had their screening colonoscopy. We know what their process, we know that they have a problem, and now we need to keep them in a surveillance program. Keep those things different in your thinking, and it'll help make these decisions easier in regards to your patient care. All right, screening guidelines. Divide the patients in two groups. They're either average risk or they're high risk. And average risk patients mean that they have no other conditions, no other family history, nothing else that would lead you to think that they are at any increased risk than the average person for colorectal cancer or for polyps. Most individuals should be entered into a prevention pathway, which is why it's phrased this way. Cancer prevention test should be offered first. Most patients will agree to that, and most patients will agree that it is a easy one-step test. Not easy. It's a one-step test. If they do have a polyp, it can be addressed at the same time as the colonoscopy. Say they have the virtual colonoscopy and they see a polyp, then what? They have to go get a second test done. So most patients, though, will agree to a prevention pathway, and it should start at age 50. There's one of the guidelines, which is the ACG, which recommends that you consider screening African Americans at age 45. Some of the insurance companies will do that, some won't. But just I want you to know that there's at least one guideline that suggests that. Cancer detection tests. This should be offered to individuals of average risk who, for whatever reason, decline a prevention test. And the preferred being the FIT test, as we mentioned. Is there any questions about that slide in terms of average risk, prevention test versus detection test? Now, what's increased risk? Well, the first thing that is not increased risk is if you have a single first-degree relative greater than 60 years old, that individual is average risk. Increased risk is if you have one first-degree relative less than 60 or two first-degree relatives of any age. That's the definition of increased risk. Some of the guidelines are starting to include adenomas in family members, and I'll tell you about that in just a little bit. But in general, it's a cancer in a first-degree relative less than 60 or two individuals of any age that are first-degree relatives. So 2 second-degree relatives, 3 third-degree relatives, those are not included in high-risk categories. And the recommended screening is you begin at age 40 or 10 years younger than the age of diagnosis of the affected individual. So if you had a family member who's 45, then you would start at 35. If you have a family member at 59, you start at 40. Okay, and then they would enter the surveillance every 5 years. Now, not everybody, of course, needs a colonoscopy. Not everybody needs a prevention or detection pathway. So let's talk about age and comorbidities. First, age. We want to do age-appropriate and we want to do comorbidity-appropriate screening and surveillance tests. The older the individual, as I said, the more likely they are to have an adenoma. But the good news is that recurrence of adenoma is unaffected by age. The other thing is that older individuals prep more poorly. They're at higher risk of complications, including perforation, 30% greater risk. and there's a minimal reduction in life expectancy. So when I talk to people who are 75 and older, then I like to be sure that I document, I am not sure that doing this test is going to prolong your life, and I am sure that you're at increased risk of complications, and then I talk to them about whether or not they want to have the test done. So somewhere between 75 and 85, the risk-benefit ratio changes. And individuals of that age, if they're going to do the test, they need to know for sure why, what they're getting into. So a 65-year-old, I think it's very appropriate that a 65-year-old be sent over and say, he needs a follow-up colonoscopy because he had a tubular adenoma 5 years ago. But I think it's probably less appropriate for a 75 or an 80-year-old to be sent over and said, hey, you need to go get your colonoscopy done because you had a polyp 5 years ago. We need to talk to them and document this first. Okay, what about comorbidities? The reason that we do colonoscopies, the reason we do screening and surveillance endoscopies is to improve life expectancy and to decrease morbidity in the future. All of the guidelines state that if you think that the life expectancy is less than 10 years, then don't recommend an endoscopy. If they have multiple comorbid conditions, if they're on oxygen and they go to the heart failure clinic, the likelihood of them living beyond the advantage of the endoscopy is low. So they may be inappropriate for surveillance or even screening endoscopies. They're at increased risk because of their heart and lung conditions from the sedative. They're at increased risk from any complication from the procedure. So age-appropriate and morbidity-appropriate screening. All right, so here's a question for y'all. Which of the following patients would you recommend for surveillance, for endoscopic surveillance? A 55-year-old with 3 hyperplastic polyps, 50-year-old female with 2 serrated adenomas, a 48-year-old man with 4 colonic polyps, or a 77-year-old woman with 2 small adenomatous polyps. So you can think about that for just a second. And I'm going to go ahead and help you know the answer. Remember that surveillance is we're going to keep an eye on somebody that we know who already has a condition. And if they have a neoplastic polyp, like a serrated polyp or adenomatous polyp, they're the individuals that we want to keep an eye on. If their polyp is non-neoplastic, if they have either a hyperplastic or an inflammatory submucosal process, lipoma, then they are not somebody I need to keep an eye on. You basically just have to memorize this. These are the guidelines published a year or two ago on polyp timing. This is surveillance timing, and it's not really that hard. It's either normal, which is so. If you've got a normal colon, hyperplastic polyps, the reason it says no change, this is actually comparing the 2012 update to the 2008 guidelines, but really no change. Hyperplastic polyps, just think of that as a normal colonoscopy, and when would they need a surveillance colonoscopy? Never, right? They would never need a surveillance colonoscopy. Those individuals would be returned to the screening population, and then 10 years later you would reevaluate them for age and morbidity appropriate screening and decide if you think that they are at that point still a screening candidate. So that's normal. This is almost normal. If we were in England or Europe, somebody with 1 or 2 small tubular adenomas, the European recommendations are 10 years. So they consider this as better than low risk. They consider this as normal. So in our country, it says 5 to 10 years. And what I tend to do is if you're 50 and you have 1 or 2 tubular adenomas, I'm going to probably see you back in 5 years and check and see if there's any growth. If you're 68 and you've never had a colonoscopy before and you have 1 or 2 small little polyps like this, I'm probably going to say your chance of getting colorectal cancer is super, super low. I'm not sure that I would recommend you having it done again in 5 years. I would maybe put those people more on the 10-year plan. So you've got normal, low, and now you've got higher grade kind of process here. And so memorize these. These are the things that you're going to probably see on your board test. Somebody with 3 to 10 adenomas, somebody with adenoma that's greater than a centimeter, or somebody with any of the more aggressive features, which is a villus or tubular villus type process. And then this is like super high, I guess, because there's so many of them. And so they need to be done in less than 3 years. And then the piecemeal resections in 2 to 6 months. If they have 10 adenomas or more, if I'm doing their colonoscopy and it takes 45 minutes to get their polyps out, the patient's getting tired of it and I'm getting tired of it, I'm going to probably bring them back in a year or two and recheck them. If all of them are real low-grade dysplasia, they don't have any high-grade dysplasia, and I took out 10 of them and I think I've gotten most of the big ones, I'll see them back in 2 years. If I'm not sure how many I've gotten out, or if their prep is bad or something, I'll see them back in a year. So this is a little bit of a, you're not going to be quizzed on that or tested on that one, but just so you know. So what's the right answer here? Would anybody enter a 55-year-old with hyperplastic polyps in a surveillance program? No, good. Who would enter a 50-year-old woman with serrated adenomas? Serrated adenomas are neoplastic. They have malignant potential. Who would enter a 48-year-old man with 4 colonic polyps in a surveillance program? What do I need to know before I would enter him or not enter him? Yes, I want to look at his path. I want to know what his path report is. That's one of the most common things I see is people sent to the GI office for follow-up of his polyp. And I go back through the records and they had a hyperplastic polyp or they had something that was completely non-neoplastic. What about a 77-year-old woman with 2 small adenomatous polyps? No, right, because of her age. And if she was 71, I might not do her again, because remember that 2 polyps or less is close to normal. That's close to normal. Yeah?
When you go back to that, for 1 and 2, you said that it's 5 to 10 years. What grade of recommendation is that? Or is it just expert opinions or just the data on that?
Which one? The 5 to 10 years?
Yeah, the 5 to 10 years for 1 and 2's polyps.
Yeah, that's what grade of?
Label recommendation.
Yeah, I don't know what. Yeah, I do know that it's we're a little more conservative in the States than they are overseas in terms of the guidelines for 1 or 2 small polyps. Okay, so these are your low risk, kind of real small. They're magnified. That's the snare, which is like 3 millimeters. So you can see the base of this is about 3 or 4 millimeters in size. Here's a polyp right here. This is going to be about a 6 millimeter polyp. It's very small. If I had one of those little small things, I might want to come back in 5 years. Again, like I'm saying, if you're in your 70s and that's the first endoscopy you've had and this is the only thing you had, you might never want to come back again. This is a little more of a higher risk polyp, 3-year surveillance. You can see this is the head of the stalk is here. This is the stalk, and the polyp is, you can see the head of it here. It's about half the size of the circumference of the lumen. Here's another large polypoid lesion in the colon. The size of this makes it a higher grade lesion, so they need to come back in 3 years. If there's a villus component in this, then that also would have you bring it back earlier. This is probably the highest risk. See this lesion here that's multilobulated? It's kind of stuck up against the wall of the colon. We had to cut this out in pieces, multiple cuts, and this is the base of it now. And then the problem is that you get edema around the margins like this, and so you're not really sure you've gotten all of the polyp out. And I tell the patients that we cut all the way around, but we're not sure that we got all the roots out, and so we're going to bring them back in 6 months, and this will have either healed up nicely or there'll be some residual polypoid material there that we can resect. These are some special cases, and most of you are going to be familiar with these, and some of this we've already been over, but colorectal cancer, you see them back a year later, and if it's normal, then 3 years, and if that's normal, then 5, and then they go back into the same kind of routine surveillance intervals as someone with a first-degree relative. And I talked about the family history, age 60, cut off there, and we'll talk about Lynch and FAP in a minute. And then remember, IBD, if it's pancolitis, it's 8 years. If it's just left side, if it's a very limited colitis, then they have to have had the illness for longer than that. So individuals who have had proctitis for 6 or 8 or 10 years, they're not individuals that you're going to do yearly or biannually surveillance. And this is to, again, I just want to reemphasize, this was actually from the American College of Physicians from 2012, and they pointed out that go ahead and individualize your assessment of the patient risk in regards to their age and comorbid conditions. Start at age 50, and if you want to choose a detection pathway, then choose that with the stool cards. If they're young, I mean, if they're at high risk, you begin at age 40 or 10 years earlier. And they actually were the strongest. They came out and said, stop at age 75. Don't offer it anymore. The other two guidelines say don't do it after age 85, and they say how did they phrase it? Don't recommend it between 75 and 85. So what I think is happening here is we're slowly turning down or lowering the age at which we think that these tests are of value. And one more time, not everybody needs a colonoscopy. There is some data showing that there's overuse. There's overuse of endoscopy in terms of surveillance, people coming back every year or two, and individuals who are getting surveillance or screening colonoscopies at an age that's inappropriate, or that have comorbid conditions that are inappropriate. So keep that in mind, all right? Here we go. Here's a question. A 37-year-old presents to your office for evaluation. His mother had colon cancer age 62. He has an uncle that was diagnosed with colon cancer age 48. He had a grandfather with colon cancer, and he had a grandmother with endometrial cancer. So what does he have? What probably does he have? You don't know for sure. Lynch. Okay, so we're thinking Lynch syndrome is the more common of the two genetically determined tests. And so now that you know that it's Lynch syndrome, they're asking you to decide, what do you do next? Do you do a blood test of the mother for microsatellite instability? A microsatellite instability is something that you do from the tissue, so you don't do it on the blood. Would you do a colonoscopy when he reaches age 50? No, right? You would start that much, much earlier. Referral for genetic counseling, which is the right answer here, or a blood test of the patient for a mismatch repair gene mutation. If you knew that a member of the family had a specific mismatch repair problem or gene abnormality, then you would test him for that same genetic abnormality, but you don't just draw a mismatch repair gene analysis at this point. So the hereditary colon cancer syndromes, there's two basic ones that we talk about, FAP and Lynch. There's also a whole set of kind of interesting and rare Hamartomatous type polyp syndromes. Hamartomatous, anybody know what that means? It's the tissue that's normally there is just disorganized. So it's disorganized normal tissue, and it grows up, and sometimes within that disorganized tissue that is typical of that area, you will develop neoplasia within it. So you can have hamartomas in the lungs, you can have it in all the way through the bowel and in different organs. Both of these syndromes have two different associated syndromes, and both of these, fortunately, one is brain and one is skin. So that's a good way for you to remember it if you haven't, because you're going to have to probably memorize this. The Lynch syndrome, the brain part is the glioblastoma. So I don't know, the Grinch that stole Christmas or something. Just remember glioblastoma and Lynch, and then the Muir-Torre syndrome is the name of the skin-related syndrome. The polyposis, it's medulloblastoma, or the Gardner's is the skin-related process. Lynch syndrome is autosomal dominant, and the way it works is there's these repetitive areas in your genome, these multiple base pairs that are very repetitive and very monotonous, and the mismatch repair genes kind of keep those intact. Those are kind of lead-ins for the coding for the next segments. They're sort of like breaks between information. And they can run an analysis on the tissue and tell you whether or not these satellite areas, these repetitive base pair areas, whether they are too big or too small, whether they're normal or not. If the microsatellite instability areas are greater than 30%, which means that the abnormality is greater than 30%, they call that microsatellite instability high, and that is a lead-in for you to diagnose Lynch syndrome. If the microsatellite instability is high, the next step would be to do an immunohistochemistry test on the tissue, and they'll look for these type of mismatch repair genes like MLH1 and MSH2, which are the more common. If those are aberrant, then they'll move to genetic testing. So that's kind of the sequence, and that might be what you would be tested on, is what you would do to diagnose this in terms of testing. What's the most common extra colonic malignancy in Lynch out of all these? Uterine. So it's 60% in the females that have Lynch syndrome, and like I was telling you earlier, that this syndrome is exactly like the normal Adenoma-Carcinoma Sequence in the sporadic cancers, except it's much accelerated. It's almost like it's got a jump start because it's got this autosomal dominant component, and the mismatch repair genes aren't working. How do you diagnose Lynch clinically? Are you all familiar with the 3-2-1 kind of tool here from the Amsterdam criteria? It's 3 relatives with Lynch-related cancers, 2 or more generations. 1 has to be a first-degree relative, and 1 has to be less than age 50 with the diagnosis. This will pick up about 50% of Lynch kindred. The other way, and probably an important criteria, is the Bethesda criteria. And here's something to keep in mind. If you're seeing somebody with colon cancer or ovarian cancer or uterine cancer, and if they've had 2 of those, if you have an individual that's had colon cancer twice, those are people to start thinking about they could have this mismatch repair gene problem or Lynch syndrome. And then there's some more criteria which you can familiarize yourself with as well. It's a high incidence of colon cancer by age 46. You can see this is the incidence. And then I talked to you about the variants. The Lynch is glio-Lynch, and then the skin syndrome is the sebaceous neoplasms. So that's just kind of one of the buzzwords. And so as far as like your management of a kindred, does anybody have a kindred with Lynch? Anybody? No? What about FAP? Does anybody know of FAP patients? Yeah. It's interesting to me that I've seen more FAP than Lynch, but Lynch is supposed to be almost twice as common, and it may be where we're living. And so those of you who practice other areas, just you keep an open mind about Lynch. You should find it. They say it's 3% of colon cancers. But the way that we manage them is they need an annual colonoscopy after age 40, and that is because a lot of the Lynch tumors are on the right side, so you have to get all the way around to the right. Because it's an accelerated pathway, they need the endoscopy on a yearly basis. And many experts recommend that the females have a prophylactic hysterectomy, and then the second most common malignancy, which is the kidney, with ultrasounds every year or 2. FAP, it's APC mutation that's autosomal dominant, and it's just hundreds and hundreds of polyps, as you can see here. These are just like multiple polyps all through the colon. Other buzzwords with FAP include the osteomas and the supernumerary teeth. What's the second most common cancer in FAP? You might see this on one of your boards. It's ampullary cancer, or it's proximal duodenal CA. And the risk of cancer is higher in FAP than in Lynch. You can see that 100% of people will get colon cancer with FAP. These individuals in the family, you can do a flex sig starting in their teen, at adolescence in family members. So, and the reason for that is that FAP is throughout the colon. You don't have to do a colonoscopy every year, every 2 years. And then when you start detecting polyps, then that's when they need to have their colon out. So, I've followed children starting at age 12. That's about when I would start doing a flex sig every year or two. And then once they start developing polyps, and that's usually in their early 20s, although individuals as early as in their teens have been diagnosed with colon cancer. And then these are the variants, the Gardners, the Buzzwords are desmoid tumor, and the fibromas, that's the skin, and then the brain is the medulloblastoma. There's also some attenuated FAP illnesses that you may or may not, you probably won't run into, but they have fewer adenomas, but they're managed the same way. Hamartomatous polyps. What is this disease here with the melanin, the deposits in the lip and on the buccal mucosa? Peutz-Jeghers, good. And it's rare, but it's a visual, so you might see a picture of that. And it's associated with what other cancer? What cancers? So it's associated with the sex, like ovarian and testicular cancers. Those are the prominent ones. The polyps tend to be more in the small bowel, then in the colon, then in the stomach, so they'll get small bowel cancer. Tuberous sclerosis, the buzzwords there are mental retardation, seizures, and angiofibromas. Cowden disease, that's super rare, but the buzzword is this trichomonas, which is a papule with the varicoid growth, and that's kind of what you see in these pictures. Cronkhite-Canada Syndrome, the buzzword here is non-inheritable, and then they get these manifestations where they lose their hair and they get nail bed changes, hyperkeratosis, and they all of these get these polyps in the stomach and in the small bowel and the colon. All right, so what is sebaceous adenomatous and mental retardation? What is that? Right? Tuberous sclerosis. CNS tumors. Medulloblastoma is which? FAP, and the Lynch Syndrome, glio goes with Lynch, right? Which of these has the ovarian or testicular tumors? Peutz-Jeghers. The melanin deposits? Peutz-Jeghers. The trichomonas, I don't even know how to pronounce that, sorry. Cowden's, great. Alopecia, hyperkeratosis. Right. There's the melanin. Sometimes it fades on the lips, and you have to look in the buccal mucosa. Okay, we can do a couple of these scenarios, and then we'll finish up if that's okay. What do you recommend to a 35-year-old man whose brother had colon cancer at age 45? What would you recommend in terms of his screening test? What age? Right now, yeah, that's exactly right. Okay, what about a 40-year-old with a mother who had colon cancer at 65? At age 50, right? They would start because this person is average risk, right? What if the 40-year-old had a mother with colon cancer at 65 and a father at 70? So that's 2 first-degree relatives of any age, which means they're high risk. Okay, so that individual would start at what age? 40. They would start now. And that's another thing is like, when you guys are taking histories of people, one of the things that we can do is if you have a patient who's had colon cancer is find out from that patient who else in their family has had it, and then talk to them about what their children might need. Because sometimes we don't get to talk to the 40-year-olds. We don't get to take histories on them. But these are the people that we want to kind of try and get screened. What about a 40-year-old with an aunt and an uncle with colon cancer? So this is 2 second-degree relatives. They are not at high risk, and so they would start at the normal age of 50. Okay, so remember the differences with second degree and first degree. 45-year-old African American without any family history. Yeah, one of the guidelines, as I mentioned, is encouraging us to try and screen African Americans earlier, and if their insurance would permit it, maybe you can get that done. So these are surveillance questions, and so that's one thing. You can talk about in your mind. You would think, when do I start screening, and what do I recommend in terms of surveillance? And so here's a colonoscopy shows a 1.5 centimeter tubular adenoma. When would that person? Is this a normal, low, high, or super high? It's high, right? So it's greater than a centimeter, and so that would be 3 years. Good. This one shows 1 sub-centimeter tubular adenoma. Is that normal, low, high, or super high? This is either normal or low, right? Remember I showed you the 5 to 10 year? So this to me, I think, if you put 5, you're going to be right on the test. If you talk to your 70-year-old patient and they had 1 sub-centimeter tubular adenoma at age 69, I am not sure that I would have them do another colonoscopy at age 74. All right. This shows 3 sub-centimeter tubular adenomas, low. Is this normal, low, or high? Yeah, this is classified as high, 3 to 10 tubular adenomas, which means they would follow up when? 3 years. Colonoscopy shows 12 tubular adenomas. They're all small, but there's 12. Is that low, high, super high? Yeah, they consider that super high, and so that means that you would do it in a year or 2. 4 hyperplastic polyps. Normal, right? Follow up in 10 years. Here's a tuberous adenoma of 0.5 centimeter. Is that low, high, super high, or normal? Yeah, somebody said high. It's low because of the size, but it's high because it has the villus component. So anything with a villus component, we would see back no matter what the size in 3 years. Or if it's piecemeal, then you'd see it back sooner. But this is considered high, so it'd be 3 years because it's got the villus component. So we're back to kind of where we started. We start our screening at age 50. Colonoscopy is preferred in general at age 50, and then we want to stop somewhere around 75 to 85. And please let's talk to the patients and not just do that. Not recommend that test reflexly in older individuals. My mom lives in a nursing facility and I talked to the ladies and there's a couple of men there, but they're all in their 80s and above, and I was explaining to them about the risk and the benefit and so forth, and once all of them understood, then all of them were of the opinion that I don't really know that I need to have this done again. And I guess that as we age, we perhaps become more and more likely to say if it's not broke, then I'm not going to fix it, particularly when the risk goes up. So I think most patients are very reasonable when we have a very healthy conversation and talk to them about the risks and benefits and the advantages of these tests. Colonoscopy in most of the groups that I showed you, and most of their recommendation is the one that is most preferred. However, go ahead and let's try and get more people into the process. And if somebody won't do a colonoscopy, consider diagnostic tests, consider CT virtual colonoscopies, and so forth. And that's kind of what this is talking about, the detection test. Remember the family history cutoff, and then there's actually 1 or 2 guidelines now that are saying that if the family member has not only colon cancer, but if a family member has a polyp that's a tubular adenoma or a high-grade polyp, then we will start considering them as part of the individuals that are at increased risk. But that's not there yet. Just keep an eye on that. We might be modifying that. And then advanced adenomas, mean increased surveillance in the simple adenomas. We would reduce their surveillance. Okay, any questions? That's a little quote about a guy from Ephesus whose name was Soranus, who described ulcerative colitis. That's kind of cool. What questions do y'all have? Yes?
With the advance of colonoscopy and screening, what's the percent of reduction of colon cancer?
Yeah, colon cancer is being reduced by about 3 to 5% per year, and so there has been a decrease in the incidence. But we're still running into patients that have never been screened and never been in any detection or screening test at all, preventative test pathway. Any other questions? Great, y'all have a good weekend. Thank you for your attention.